Good evening, everybody. I'm Dr. Kelly Kirksick-Frisella. I am the Director of Professional Relations for Revolution EHR, and it's my pleasure to welcome you all this evening to our CE event that we're having for all of our doctors. I am going to just really quickly go through just our typical housekeeping before I make the introductions here. As you know, this is live CE, so you do have to be live. You have to be participating and be present for the entire time to get credit. When you registered, you should have submitted your OE tracker number, and that will be used. So we will make sure that the work gets done for you, that gets forwarded on to COPE for your CE credit as well. With regards to this being recorded, we will be recording this webinar. It will be for viewing purposes only. You will not be able to get CE after the fact. So if in the event you do want to be able to view the webinar and go back and listen, you'll certainly be able to do that. But CE credit will not be provided after the live event. If you have questions, just a few other things. If you have questions, we will, again, try to make sure that we get everybody's questions answered. You may go on ahead and hold your question until the end. I will try to kind of monitor the questions. So if you do have a question, you want to post it. If we can find some time during the presentation where it's not too disruptive, we can make sure that those questions get asked as well throughout the presentation. But we do encourage questions if you all have any. So without further ado, I just wanted to take a moment again to say it is my delight and privilege to be able to have the Neurovisual Medicine Institute here this evening. One of the things that I get to do in my role at Revolution that I truly enjoy is I have the opportunity to network with optometrists really in so many different facets of practice. It's truly a joy to be able to get to see what everybody does on their day-to-day. And this group in particular, I had no idea what neurovisual medicine was a year ago, and it's been quite a journey having the opportunity to learn what this group does. And they make such an impact on patients really all over the world that I'm looking forward again to them sharing a little bit about what they do, the research and the impact that it's made on patients. So without further ado, I am going to go on ahead and introduce at this time their Chief Strategist for Practice Growth, Matt Rosner. Matt,
hey,
welcome.
Thank you so much, Kelly. And I want to just give a quick shout out and thanks to the Revolution EHR team for helping us put this webinar together.
Trouble hearing.
Matt, is anybody else having a hard time hearing Matt?
No.
Yes, Matt, your mic is not, it's very muddy.
How about now?
Better.
Much better. Yes. Yes,
okay.
it is much better.
Technical glitch.
Please start over.
Okay. Yes. Okay. Thank you so much, Kelly, for having us and for the whole Rev EHR team for collaborating on tonight's webinar. I know many of you are already using their software, but if you're not, definitely take a closer look. We've seen an impact that it's having a lot of our specialty clients. And we're really happy to be working together with them to streamline the way that specialty care happens on the black slab of glass on your screen that you're looking at all day long. So we'll have a poll at the end to learn more potentially about us as well as the team at Rev, and we'll make sure you get connected. Okay. So as eye care professionals, we focus on helping patients see more clearly. But growing evidence suggests that the visual system plays a much larger role in how patients feel, physically, emotionally, and cognitively. Many patients continue to struggle with anxiety, dizziness, cognitive and brain fog, even after receiving thorough care from trusted providers. These lingering symptoms are often difficult to explain and difficult to treat. Tonight's session explores one potential contributor that's gaining attention both in research and clinical practice: binocular vision dysfunction, or for short, BVD. You'll hear tonight from two clinicians, one in optometry and one in psychiatry, who have been working together to better understand how subtle visual misalignments may contribute to symptoms often considered psychological or neurological in origin. Together, we're going to look at real-world cases and early findings that offer new insight into these challenging symptoms. Our hope is to share emerging knowledge, invite thoughtful dialogue, and support your ongoing efforts to provide the best care for your patients. Now, when we do webinars, one of our favorite things to do is a bit of back and forth engagement, because we know you're all there, and we want to have at least a little bit of conversation with you through the Q&A as well as through the polls. So now is the first poll of the evening, and because it's a bit of a one-way conversation, this will be the first time for us to sort of talk with you and learn who's here tonight. And so the first poll we're going to launch just now. You'll see it on the bottom right of your screen. There should be a little red dot, polls, and it looks like we've actually got the second poll, but that's okay. Oh, you know what? Just kidding. This is the correct poll. So go ahead and share, how familiar are you with the link between binocular vision dysfunction and mental health? And we usually keep these polls on for about 30 to 60 seconds. And amazing. We're already at more than 2/3 engagement. I like to get to 80% engagement before we close the poll here. Okay. You guys are doing great. Thank you so much for engaging with us and sharing your votes. All right, we'll give 10 seconds and then we're done. We're really close here. Okay, let's close the poll and look at the results. So the highest demographic of people here tonight are ones that are brand new to this connection. So excited for you to be here, and we're excited to share some of this insight with you. The next biggest group is 29% have suspected a link, but haven't pursued it clinically. And then from there, some of you have seen the overlap in your patients and looking for tools. And then a small minority, which is you've already had protocols in place to evaluate these patients, which is wonderful. We're glad that you're here tonight. Okay, so that's a little bit about who's in the room tonight. But without further ado, I would like to introduce Jenna Schock, who is a psychiatric nurse practitioner and both a clinician and a patient, who's going to share a bit about her story with BVD and how she found her way to this conversation tonight. Jenna, take it away.
Thank you. Thanks for having me. I like talking about this. I think as much as you all didn't get into optometry expecting that you were going to be digging into psychiatry, I did not get into psychiatry thinking that I was going to be digging into optometry, but it has been a wild ride for about the last 7 years now. So in 2018, I was doing clinical work right before I graduated with my NP, and the practice that I had worked at was a family practice. Her wife had gone and seen Dr. Debbie and been evaluated. They were trying to assess all possibilities for whether she was looking at a brain issue, an eye issue. She was having all kinds of symptoms that were relatively new. Didn't relate it to me, but Doc came back and she kept looking over at me while I was working, and I'm sitting at my computer typing like this, and she's like, "Jenna, you always have your head tilted to the side." Yeah, okay. Then when I get up and I stand still. And then I start walking, because otherwise I'm going to be pretty dizzy. And I usually look at the floor when I'm walking. And she says, "Listen," she's like, you need to take this test." I was like, "What are you talking about?" She's like, this eye test, like all of the symptoms on here, you have all of these symptoms. It's like, "I just got new glasses. My eyes are fine. Just work with me. So I did take the test. The test called the BVDQ, and you'll hear a little more about that tonight if you're not familiar with it. But on that test, if you score 15 or higher, then it is presumed that likely you would benefit from microprism treatment. I scored a 58. And so I set an appointment. I had it out and met with Dr. Debbie. I was having issues that I'd been having my entire life. So motion processing issues. I could not be in a room where one of my kids or family members had turned on a video game. If I saw it out of the corner of my eye, I was instantly nauseous. Certainly couldn't handle 3D things. I sat at the edge of Universal Studios while all kids went on 3D rides. There was a lot of life I was missing out of. I couldn't be a passenger in a car. I could only be the driver. Very tired all the time. I was a student for a very long time and did not read. Like, I couldn't read. It was a huge chore for me to read. So I would come up with every other alternative to try and get all of the information and content if I didn't have to read a textbook, because that was too much for me to do. I ended up with headaches, wasn't processing and retaining the information. And when I got there, I'm going through and doing some of the screeners, and all of these symptoms, they mentioned those, which were certainly a big deal, but also anxiety, some depression. I've been dealing with this for 35, 40 years at that point. I thought it was normal. By the end of that appointment, life was looking a little bit different, right? So we had gone through and we tried the different prisms. We found a set at the beginning of the appointment. Dr. Debbie would ask, when you stand up, how do you feel? And I'm like, a little wobbly. I got to stabilize myself first. I'd take a walk down a hallway, and you'll see some examples of that later. I would pretty much always veer to the side, and like I mentioned, stare at the floor. I was never a big one for going to places with crowds or new places, department stores, things like that. They were overwhelming, and dealt with a lot of anxiety doing that. When we put those prisms on, I stood up. I had no anxiety. I felt more confident. I felt taller instantly, much more stable, walked a straight line down the hallway. I went out to the lobby with my daughter who was with me, and I kept going, look, I can do this. And it doesn't, I'm not getting dizzy. I'm not reacting. And from there, I started looking at, well, if this can have this much of an effect on me, I wonder how much that's affecting my patients, right? We see a lot of patients who are coming in with treatment-resistant depression, treatment-resistant anxiety, agoraphobia, concussion history, traumatic brain injury history, all of those sorts of things. So there's definitely a crossover in the people who are more prone to seeing a binocular vision dysfunction. So we had gone back and forth, and we were talking about studies, just because I'm a data numbers girl, and they were sharing with me that basically 20% of general population is believed to be dealing with binocular vision dysfunction. Like, well, if so many of them are seeing these symptoms, I want to know what kind of percentage of my patients might be screening positive. So at that point, I was like we got to play with this. I'm curious. I need to know. So we set up at the clinic that I was working at the time, and for 3 months, we had all of the patients who came in with their intake paperwork. They also completed a BVDQ. And I'm going to share my screen for a moment here and tell you a little about some of what I found while we were doing that. So like I said, I had just a need to know. So we started this clinical study just to look at the prevalence amongst my patient population, knowing, again, that BVD is present in approximately 20% of general population, approximately 50% of all traumatic brain injury and anoxic brain injury patients, which we certainly see in psychiatry. Approximately 50% of those who have reading or learning challenges, including ADHD, learning disabilities, dyslexia, etc. So I want to know how common in psych patients. So I was working at a small outpatient rural affiliated psychiatry clinic, and we focused in on patients ages 15 to 70 seeking treatment for either depression, anxiety, or ADHD. And they could be treatment naive, or they could be people who had seen a number of different specialists at that point in psychiatry or otherwise. So results, we had 123 of the screening tools completed. Of those 123, 76, so that's a almost 62% rate of positivity, scoring that 15 or higher on that test. It's a range, so you can see, it wasn't 50 of those down at the very bottom of it. It was pretty well dispersed throughout, including one as high as, I think it was 73 that patient had. And I started screening everybody after that, right? I certainly didn't mandate the testing or anything like that, but educated them. They went through the same process I did, telling me that this was ridiculous, that their eyes were fine and they could see everything just fine. But being able to share my experience with them, got a lot of people to go up. And a lot of my patients came back with glasses, and it wasn't necessarily what I would call a monotherapy. It didn't always cure all of their problems entirely. But it absolutely made a high impact on the symptoms that we had previously labeled treatment resistant. They weren't responding to medications, which, if we know that the symptoms are being caused by an eye dysfunction, that makes total sense that they're not responding to the psychiatric medications. So what does all of that mean? Well, first, we need a lot more research and education into the relationship between psychiatry and binocular vision dysfunction. Certainly much of the psychiatry world is not aware of the connection, just as much of the optometry world is not as well. Myself, along with the patients that I sent up there, consistently hearing the words back, life altering, and the difference that it was making when they received the treatment. And often these symptoms that they were presenting with were not visual in etiology. So it needed to be a part of a regular intake screening, because someone's not going to identify, I think I might have an issue with my eyes. So when we're looking at a differential list, then we have to make sure this is a part of it. So I wanted to share a couple of specific patients with you. So this first one, 16-year-old female with agoraphobia, ADHD, sensory processing disorder, reading difficulties, and intermittent suicidal ideation. Life-changing, feel so much calmer now. I got a job. We're working on getting me back to in-person school. These glasses have actually saved my life. I never thought I had a problem with my eyes. Highly relatable. I certainly didn't either. 30-year-old male, major depressive disorder, generalized anxiety disorder, and post-traumatic stress disorder. So it's impossible to formulate the words needed to explain how putting on a new pair of glasses changed my day-to-day functioning. Something that's now just a trip to grab a loaf of bread used to be an uncomfortable experience that could induce a panic that would impact the rest of my day. As a child, I was expelled from the school bus due to daily nausea-induced vomiting that Dramamine couldn't touch. Now I ride as a car passenger without issue. I've seen a drastic reduction in my fatigue, anxiety, and neck muscle stiffness, but most importantly, my confidence has soared. I never imagined my therapist would refer me to an eye doctor, but more than that, I never imagined that an adjustment in glasses, which I'd been wearing every day, could give me back a piece of myself that years of anxiety had stripped away. My BVD diagnosis and treatment has not only given me more control of my eyes, but more control of my life. We will give you one more here. It's a 19-year-old female, severe social anxiety, ADHD, concussion history, depression, and post-traumatic stress disorder. She had actually dropped out of school at 17 because the anxiety involved in being in school was just too much for her to be there. These glasses are a godsend. They helped me be able to get past my anxiety and get my GED so that I could apply to college. They gave me the confidence that that required. Besides that, the little kid who used to love reading and then stopped entirely now has her nose buried in books again. I will give you a little bit of a spoiler there. That is actually my daughter on the last one. I did not slide that BVDQ over to her until I'd probably had my glasses for about 3 years at that point. her symptoms were different from mine. And so I didn't see it, right? She didn't have the motion processing issues that I had, but she did absolutely have the agoraphobia, the social anxiety, the sensory processing issues, the difficulty with the reading. And if I looked backwards, much of that had changed following a mild concussion that she had had at school. But following the glasses, she is now a junior in college getting her social work degree. Straight A's, loves reading again. Her life is completely different, due in large part to the glasses and the difference that that made. So what do we do with that? I'm screening all my patients, you know, whether they come in thinking they have an issue or they don't. If I've got a new patient, I'm screening them. It's just a part of that differential from the get-go if they're coming to a psychiatry office. But I find that many of them have been to many different specialists, and we'll talk about that a little bit later too, with possible misdiagnoses and all of the things that they had been through prior to this. I am trying to do presentations like this. I'm presenting to psychiatry audiences, working on increasing the knowledge. So thank you for being here and learning a lot about this tonight. The more people we educate on that, the more we're going to be able to get broader coverage for people to be able to seek treatment in an affordable way. And when we know that that's not only making a difference in what they see, but in every bit of their ability to interact in a pleasant and happy way with the rest of the world, life-altering, life-saving. I can't tell you how many times I've heard those words, and in psychiatry, those words are gold. We like that a lot. So we'll keep working with this and building the knowledge and spreading it around and seeing what we can do.
Thank you, Jenna. That was wonderful. And the next thing we're going to do, we're going to get back to you all in the audience for our next poll. And the question for this poll, and you'll find it in the same spot, the lower right corner, or maybe it'll pop up. Here we go. Is how often do you see patients in your optometric clinics with anxiety, depression, or any sort of attention disorders? And we'll do another 1 minute on the clock here while everyone shares their insights, and then we'll share back. Amazing, that was fast. I don't even think we need to wait a full minute. All right, we'll take about 5 to 10 more seconds, and then we'll jump in. Okay, well, as the last couple votes are coming in, it's really interesting to see the great majority of you are already aware of this, seeing this, having conversations with patients about this. It's both exciting because you're already tuned in, you're already asking the questions, and now we get to ask the question, what's next, and how do we help them? So with that, I'm super excited to introduce Dr. Debbie Feinberg, who is the founder of Neurovision Medicine, as well as the Chief Clinical Director at Vision Specialists of Michigan and the Neurovision Medicine Institute, to share a bit about her story as an optometrist, starting with primary care and sort of finding her way into specialty care and microprism treatment. So Dr. Debbie, take it away.
Thank you, Matt, and thank you, Jenna, for your willingness to share and just dive into research when you saw the need was there. I'm going to share my screen right now, so hang on 1 second. No, that wasn't the one.
It is the one.
Is that the one, Matthew?
Just hold on.
No, the other one.
Are we good now?
Nope. You'll just want to share the full blue tab with the window. There you go. we're all set.
Yay. All right, wonderful. Let's just get rid of this little thing here. Good. Okay. Okay, very good. So welcome everyone. It's really wonderful to see this kind of interest in this work. And let's see if I can advance the screens.
Just do a click instead of the key.
Oh, there we go. Okay. So I'd like to set the stage, and it really begins with a double date. I'm on the far right with my husband next to me and my brother-in-law and sister-in-law. My brother-in-law is an ear, nose, and throat doctor, and he was holding up a loose prism in front of one of his eyes. And of course, it caught my eye. And I said, "Why are you using that prism?" And he said, "Well, in medical school, they thought it might help me with my reading challenges." And I said, "Well, is it helping?" He says, "Not really." So right away, I thought, all right, I'm going to examine his eyes. I'm going to see what's going on. Let's see if I can help him. And sure enough, after receiving a small unit of prism built into his glasses, he said he was no longer clumsy klutzy. His reading got better. And then he later said to me, "I need to send you my dizzy patients." And I said, "What? What would I do with them?" And he said, "I think you're going to help them the way you helped me. They sound a lot like I did before you helped me." So without further evaluations, I began to receive this population coming through my door, quite scared, quite nervous, thinking, how am I going to help them? And sure enough, what I began to see were patterns. You see me pictured here with my father, who's 99 and a half years old, soon to be 100, and he stopped practicing at 93 because of this work. It was so rewarding. And together with him in the beginning, I was seeing some fascinating patterns. The first thing was these patients had a subtle vision misalignment. And they also, of course, had this dizziness and headaches that was something they came in with, that the small unit of prism was actually helping them reduce, if not eliminate, those symptoms. Then there's a patient that came in not long after who said, "Did you give me Valium?" as she wore her prismatic correction in a trial frame. And I said, "No, is that how you feel?" And she said, "Yes, I feel so calm. My whole body is relaxing." Well, I was a psych minor in college, and that was just beyond fascinating to me to think that a pair of glasses was going to calm someone's nervous system to that level. So connection number 2, a subtle misalignment of the vision was actually causing anxiety. So here we have this symptom waterfall. We have this subtle vision misalignment, helping patients with headache and dizziness, helping patients with anxiety. And very often what we learn is that the anxiety was actually a byproduct of their discomfort or dis-ease and their disequilibrium. Fear of falling, fear of uncomfortability in large open spaces. And then, as the cascade continues, I began to see patients who happened to be psychologists, a lot like Jenna, with a background in helping patients with anxiety. As I began helping this population, they began using this questionnaire as Jenna has in their patient population, and thus began again, a continuum of patients coming in with looking for help for their anxiety, amongst other symptoms. So part 2 is going to be talking about what is binocular vision dysfunction and vertical heterophoria. So binocular vision dysfunction, or we call it BVD, the definition is when the eyes are not working together in a coordinated fashion to enable the brain to see a single image. These patients don't have to have a large misalignment. In fact, only 1/3 of the patients with BVD are diplopic, and you actually see double vision. These are also previously, we were previously as clinicians unsure of what to do to manage these phories with prism. And we also began to realize that there must be some underlying uncompensated for posture. So again, we're going back to what is this BVD? Well, in our patients, we identify that in fact they have horizontal and or vertical misalignment. It can be a two-eyed problem or a single-eyed problem. Under this BVD umbrella term, we have so many things that we learned in school about convergence insufficiency, convergence excess, divergence insufficiency, divergence excess, basic esophoria, esotropia, basic exophoria, exotropia, and then the big one that we didn't learn too much about at all, vertical heterophoria. Then, of course, there was fusional vergence dysfunction, accommodative, excess, insufficiency, infacility, and oculomotor dysfunction. So let's dive into vertical heterophoria. Definition: when the line of sight from one eye is above or below the line of sight from the other eye when fusion is disrupted. Two slightly misaligned images are sent to the brain struggles to fuse these images, and VH is the most common form of BVD in our practice. So here's a picture of a young child. You can see there is some, for sure, orbital asymmetry. So what are the types of VH? It can come from congenital, meaning patients are born with this orbital asymmetry. It can come from an acquired brain injury, such as a stroke or near drowning anoxia, or it can come from a traumatic brain injury. How can this come about? Well, we talked about the facial asymmetry. Also can come from a likely inner ear connection, as well as an innervation to a muscle that is impacted. What are the key insights for this population? We describe it as a hidden vertical, and it can be a frequent cause of dizziness in patients. Historically, very difficult to find, and these patients, in much of our research, have actually sought out up to 7 to 10 clinicians just to seek some type of relief. And it regularly manifests itself with a head tilt in these patients, trying to align the images. So part 3 is, what's this new approach to BVD? Well, it's screening plus treatment. We call it a neurovisual medical approach. So we've all heard of vision therapy, neuro rehab therapy, and we call that the active form of therapy. Then there's something called passive therapy. People have described some of our work as passive in that our patients are given a pair of prescription eyeglasses with prism incorporated into that correction, and we call it a visual orthotic device, including the microprism lenses and therapeutic tints, to name a few. So it's a step-by-step approach when we work with this passive therapy. We start with that screening tool, the BVDQ, and then we have our course of care, the microprism treatment. Historically, in many of our studies, the relief is obtained after the 2 visits of about 80% improvement. So here is the screening BVDQ, stands for Binocular Vision Dysfunction Questionnaire. 25 frequency-based symptom questions. It takes just 5 minutes to complete. To date, we have over 100,000 BVDQs screenings completed globally. I'm happy to report that we have a validation study that was published in a peer-reviewed journal in 2021 in otology, neuro-otology. And we do find that the prevalence of the many myriad of symptoms that these patients have are actually in this wheel in front of you. I'll just name a few that come to mind and that I see popping off this wheel. Falls in the elderly, unsteady gait, motion sickness, quite common, sound sensitivity, sensitivity to light, overwhelmed in crowds, and anxiety with driving, and agoraphobia, as was mentioned previously, and panic attacks, not uncommon. So what is this course of care? No. It includes a comprehensive vision exam and a binocular vision exam. We custom fit a visual orthotic, a device real time using quarter adapters, increments of microprism. We refine the prism prescription to reach comfort and clarity. And at that first visit, they receive a 50% average improvement during that first exam. So what microprism does is it actually relaxes the eye muscles that have been overcompensating for so long. And through that course of care, over 2 to 4 weeks, those muscles relax enough that when the patients return for their progress assessment about 1 month later, we're able then to fine-tune this microprism prescription with a new relaxed, more visual posture. The same tests are done during the initial eval, and we receive, oftentimes patients experience 80% average improvement upon completion of treatment. It isn't just adults who are anxious. We have many, many children who are anxious, but can't always describe how that anxiety feels to them. Here's an example of a young child, a 7-year-old, who before prism lenses was asked to draw her doctor, a doctor in our office, the same day after 0.75 prism diopters of lens incorporated with her prescription. This is how she was able to draw that doctor with confidence and clarity, and she truly knew what the doctor looked like and was able to describe it with her drawing. So I do have 2 patient cases I'd like to share with you this evening. One is binocular vision dysfunction with anxiety. This was a 33-year-old female occupational therapist who described her chief complaint as anxiety 7 out of 10 for 15 years. She was experiencing letters moving on the screen when reading. She reported dizziness, neck ache, eye strain, possible double vision, headaches, lightheadedness. She did have a history of concussions from cheerleading and horseback riding. She reread for comprehension and avoided driving due to poor depth perception. She was previously diagnosed as ADHD, sinus pain, anxiety, depression, and panic episodes. So her presenting prescription was a mild script with some cylinder, no ad, no prism. Her final prescription included a little bit more astigmatism. A farsighted left eye became a nearsighted left eye correction. And then the axes of astigmatism, you can see, changed quite dramatically in that right eye, went to axis 141 oblique. And then with the +1 ad, she required a quarter up, quarter down, quarter in prismatic correction. So what happened to her symptoms? Her biggest symptom improvement turned out to be her anxiety, went from a 7 to 1. Her light sensitivity went from a 5 to 0, and her difficulty with reading went from a 9 to 1. She described a 70% improvement in her symptoms. Reading was significantly better, and she only now got headaches when she didn't wear the glasses. Our second case is Alec, a computer programmer. His chief complaint, anxiety, 8 out of 10 for 25 years. 35-year-old male with a history of panic attacks accompanied by anxiety and dizziness. He found relief by resting in a dark room. He would often hold on to walls to manage his feelings of unsteadiness. His history included several minor car accidents and physical altercations as a teenager. He reported video games as a frequent trigger for his nausea and dizziness. Previous diagnoses were ADHD, anxiety, depression, panic episodes, and PTSD. And then his presenting prescription, he was quite myopic with a fair amount of astigmatism in each eye, no bifocal, no vertical or horizontal prism. His final prescription, there was a need for a bit more astigmatism. And then ultimately it was a half a diopter up on the left eye and half a diopter down on the right eye. What happened to his symptoms was dizziness went from 7 to 1, nausea went from 3 to 1, anxiety 10 to 5, headache 8 to 2, neck ache 9 to 4, unsteadiness with walking 8 to 1, light sensitivity 6 to 1, and difficulty with reading 7 to 0. He described a 90% improvement in his symptoms, no longer had dizziness or vertigo, no headaches unless he was dehydrated, improvement in anxiety. He was able to walk up and down stairs without holding the railing and improve neck tension. I'd like to now show you a video of a patient who was in a motor vehicle accident, and this will be exhibiting her before and after symptoms and gait. If I were to ask you to sit up or stand up from the seated position, let's see what happens. How does it make you feel when you first stand? Go ahead and take your time. Upon rising, how do you feel?
I feel unstable.
Let's
I'm ready to fall over.
fall over. Let's walk the hallway. Come on with me. Okay, go ahead. So here you can see she's definitely not maintaining the center position, the hallway drifting off to the right. And then come on back. That turn was difficult for her, and here you can see she's almost hitting the vertical racks on her way back. What happened?
And I started to feel unstable and go to the right, and then I started to correct myself, and I still kept on pulling myself to the right.
So because her script hadn't changed, we were able to put the microprism over her glasses, and you can see the change. Her dizziness went to 0, anxiety went to 0, nausea went from 6 to 2, headache. So let's see what your gait is like. I'm going to pull back from you and ask you, upon rising from the chair, see how you feel upon rising. What's your first impression?
Stable, and I'm fine and able to get up and move.
Without any symptoms? Let's do some hallway walking. Let's open the door. Perfect. And let's walk down the same hallway. You can see she's not struggling to maintain centered position. Her gait's even a bit faster. Come on back. Stopping right there, what did you notice?
I don't go to one side and I feel stable when walking. I don't feel any kind of dizziness or I don't feel like I'm listing to one side or another or trying to compensate when I'm walking, and I'm able to walk faster.
All right, thank you, Dr. Debbie. We had a couple questions, some great questions that came up during that portion of the presentation, and I just wanted to add one of them into the mix now, and we'll save one for later. So one of the questions was, with the first case, would you have prescribed a total vertical prism of 0.5 over one eye, or 0.25 over each eye?
So the prism was split between the two eyes. So the patient required the quarter balance, quarter in each eye.
Excellent. And then the other question that I want to add in before we move on to the next part of the conversation is let's see. All right, there's some good ones, but we'll keep the conversation going, and we'll add some of these Q&As in as we keep forward. So Jenna, we talked a little bit about prior diagnosis or misdiagnosis with patients. What are some of the, within your patient population, as you were sort of uncovering this in your clinical environment, what are some of the things that you saw or patterns you noticed from maybe patients' diagnoses that didn't ring true after getting the BVDQ and scoring high and ending up with a microprism prescription?
A pretty good variety. I think for some it depended a little bit on whether they were looking more at that congenital cause or more of an injury cause later, as to what types of symptoms we were seeing. In that, I would see depression a lot more if it was more of a congenital, if it was something that they've been dealing with for a long time. Depression wouldn't be the key symptom coming from binocular vision dysfunction, but there would be depression that came out of dealing with all of the symptoms that the binocular vision dysfunction was causing. So you would have that depression that would add on over time. Migraines, headaches, sore neck, stiff shoulders, muscle aches, those very common. Panic disorder, typically when out in public places. Agoraphobia, I have yet to find a single patient dealing with agoraphobia that did not screen high on the BBDQ, not one. So the correlation there is incredibly strong. Generalized anxiety disorder, ADHD, dyslexia, certainly there are times when it's not caused by binocular vision dysfunction, but there are a lot of times where it is misdiagnosed. We don't see as strong a response to treatment as we would typically expect. And then when I had somebody get glasses, their symptoms were not as strong afterwards. So there's a lot of etiologies behind the symptoms you're seeing. Sensory processing disorder, that's going to bring you in with the acoustic changes that we talked about that sometimes you see alongside the binocular vision dysfunction, that inability to process all of the visual changes in those large, busy environments. So we would see that a lot. I even saw a few that were misdiagnosed as a rule out autism spectrum because they had so much sensory processing issues. But the sensory processing issues went away once we saw the glasses. So that was a lot of it. And then, just a huge amount of, you'd see vertigo, benign paroxysmal positional vertigo, vestibular migraines, all of those we would see a lot as well.
Okay, so Dr. Debbie, you're likely, I'm assuming you're asking and listening for maybe more things than you used to listen for. Would that be a safe assumption?
Yes. I mean, I look at their physicality in the chair. They look agitated. They're sort of moving around. They're uncomfortable. They sometimes can't look me in the eye because the face is complex, and to look at the face, if the eyes aren't working together, it's overwhelming. Sometimes they'll examine the ground in front of them. So I would say, yes, I keep hearing things and understanding new ways that people describe how they feel.
And maybe a question for you in terms of maybe what's one or two things that might not be an obvious question or symptom to ask patients that you find is a regular part of a BVD patient's experience that our colleagues listening tonight might start listening for as part of their clinical work tomorrow morning?
I think the most interesting one to me in the very beginning, and even to this day, is motion sickness. We never really understood where was it coming from, but usually these patients will tell you, I have to be the driver. It's not a control issue. I can't be the passenger. For sure, I can't be in the back seat. And don't make me read anything while I'm a passenger. So I think that's a big one that pops up a lot. And clumsy klutzy. I've had people say, I wish my dad was alive because he used to think I was so clumsy klutzy. He had no idea it was coming from my eyes. If only I had had prism then, I could have hit the baseball that he wanted me to hit. So it's always interesting for them to delve into their history about the life they were living and the life that they now can live.
Wonderful. So I'm looking, we have a really healthy Q&A here, and I want to pull in a couple of these questions. Most of them are about prism, microprism production, how do we test for small increments of misalignment. So I'm going to cherry pick a couple. But I'm going to cherry pick a couple now. We've got an exit survey or an exit poll in just a couple minutes, and then we'll do sort of closing thoughts from both of you, and we'll join. We'll have Dr. Kelly join back in a minute here. Ooh, there's so many good Q&As. Where do I begin? All right. If a patient does not have double vision, how do we calculate how much prism to prescribe, vertical and horizontal?
So there are over 17 tests that we do. We do them behind the phoropter, we do them in free space, we observe gait analysis, we observe physicality, body posture, provocative movement. So I would say that measurements are, numerous, because we're still looking for, is there vertical, is there horizontal? And then ultimately, once we've gotten enough data gathered, then we have to prove it. And we utilize our trial frame every day. And if we didn't have it, it would be much more difficult for us to know, have we helped them? Can they now walk down that hallway, just as you saw that young girl doing? So I would say in this evening's 2 minutes that I have to talk about how to do it, it's a course, we're teaching a course, but ultimately the most important thing to know is that these patients do not have to live with these symptoms. This is something that is treatable, and it happens to be that microprismatic use makes all the difference for them.
Excellent. Well, and I think, when it comes to the trial framing and testing, then there's a step around production. How do we get microprisms? And there was a good question that asked, what increment do we define as microprism? So I'm going to just jump in and share that, we define microprism as 0.25 diopter increments, and the production of microprism for us is down to the 1/8 diopter. So again, one more time, it's a 1/4 diopter increments and 1/8 diopter precision, plus or minus. Okay, I'm going to do one more question, and then we'll do some closing thoughts and do our wrap. I just want to do a quick call out to everyone who is adding questions in the mix. These are amazing questions, and we'll collaborate with the Revolution EHR team to get your contact info, and we can follow up asynchronously with answers for each of you. So if we can't get your question answered before tonight is over, we'll make sure to get those answers to you after the event. Dr. Kelly, I would love for you to jump in and just sort of speak at a high level about what you're seeing on sort of the larger, because you said at a slightly different level, with Rev EHR. How does specialty care sort of weave into the future of, how you guys are working with practices and overall optometry? What are your thoughts?
Oh, absolutely. I think one of the things that we often will get asked is, our customers will have, various subspecialties, whether it be dry eye or myopia management, any type of contact lens specialty clinic, vision therapy, all of the things, low vision, that we have practices across the board that will intertwine. That, in addition, maybe they just do that solely, or they do they just dabble in it, where they like to add that specialty care to what they're already doing clinically. And I know at Rev, one of the things, probably the easiest way, one of the things that we see is with test requests, where we'll get asked, can we have this test for this specific procedure? And many times I know exactly what it is they're asking, and sometimes I don't. Certainly in the case of neurovisual medicine, I was, scratching my head at some of the tests going, gosh, I've been out of school for a while, but what is that exactly that they're doing? What is it that they're asking for? So, I would say that's probably the one thing that that we see here at Revolution in terms of helping customers would be with specialty care would be through test requests.
And this sort of, we're gonna close out the CE in just I guess this is sort of the end of the CE. There was a question, why are we working with Rev? one of the things, from a practice, and my role at our organization is to support practices in implementing and scaling specialty care. And without fail, in most practices, and I'm sure you all will feel this pain if you haven't already, when you try and change something or add something to your EHR because you're offering a new product or a new service, it's really painful. It takes a long time. You have to get on the phone, you have to go email back and forth 10, 15, 20 times. It takes weeks to months. And so, as someone who is really, one of my missions is to support workflow efficiency within the clinic. Our opportunity to work with their technical team to build and roll out these tests in a templated fashion means that you as a clinician don't have to spend hours, dragging boxes and, coding templates and things of that nature. So, I think, at a high level, it's, when we can have partners in industry that can support the ease of implementation, it means that us as practice owners and clinicians get to start doing the core work faster with our patients. So just want to give a shout out to Rev and companies who are asking our optometry clinics, what do you guys need? What do you need to make this more successful, more seamless, more streamlined? Because at the end of the day, our tools should really fade into the background, and our patients should be in the foreground. And when great tools sort of come to the rescue, that's the outcome we get. So with that, I'd love to let's do a quick round robin. Jenna, Dr. Debbie, Dr. Kelly, if you were going to sort of one parting thought for all the optometrists and folks here tonight. Jenna, let's start with you. What's one thought you might leave everybody with before we wrap?
I think it's focus maybe a little bit less on trying to identify somebody having the symptoms and maybe a little bit more on there are so many diverse symptoms that you can see with this that if I standardize including this as a screening for everybody, when we're looking at the percentages like what I found in the prevalence study that I did, it's a huge percentage of people. So if we screen everybody as opposed to just screening the people that we hear something, right? When I'm screening somebody because I hear something, it's generally somebody that it's a friend or somebody that I've bumped into in the general public that's doing something and I'm going, you need to go do this. Just go check it out. But at work, I'm screening everybody because I'm not in optometry. That's not what I do. But if I can find the way to make my patient feel better and refer them to the people who can do that, we're all winning at that point. There's never going to be too few patients to keep us all busy. So if I'm getting psychiatry to standard screen and you guys are getting optometry to standard screen, we're going to catch so many of these people before these major life disruptions really get underway and change the course of people's worlds.
Thanks, Jenna. All right, Dr. Debbie, do you want to share?
I would second Jenna's comments by saying that so many of my patients have told it's all in your head. And we all want to say, yes, it is. But my second comment is that we need to put this BVDQ in the hands of every clinician, whether it's the neurologist, the ENT, the psychologist, the psychiatrist, the OT, the PT, almost every specialty who works with patients who have all the various symptoms we've talked about. They need to use this BVDQ. So my current goal is to get it in the hands of every clinician who has a patient in my office, whether it's their side doctor, their primary doctor. They need to know about this questionnaire and utilize it as a sorting tool.
Thank you. And Dr. Kelly, you want to have the final word before we do some final housekeeping here?
Sure. I would say, it is very, very refreshing, Jenna, to see just a facet of mental health and its impact that I think by us better understanding the connection and working with you, I think that it allows us to elevate care then to the patients that we're serving in the exam room. So I just think that it's a really, really important discussion. You can turn on the television and see at any given time, there is topics repeatedly on people that are suffering from anxiety and depression and all sorts of things that are affecting really their quality of life. And I never really, until starting to, develop and foster a relationship with the Neurovisual Medicine Institute through Revolution, I never really sat to, sit and consider the impact or the connection, of one's mental health and how they're seeing. And so I think that this has just been a wonderful opportunity this evening. I know it's been a pleasure for us to be able to use this sort of as a platform, if you will, to really start those conversations, and hopefully, again, as we continue to learn from one another, the patients will win in the end, because there will be just kind of that natural referral opportunity too, back and forth from all of the specialties that Dr. Debbie had presented, not just Jenna. So for everybody here this evening, I just, again, on behalf of Revolution, just wanted to say thank you for joining us.
Thanks, Dr. Kelly. So there are a lot of great questions in the Q&A, and although not everyone, I think you actually can't see the questions that others ask, but we'll figure out a way to maybe publish a 1 or 2 page of the Q&As from tonight. I think that'll be a great resource that we can share after the event. A lot of you asked, how do I get access to the BVDQ? Great question. What can we learn more about, or how can we learn more about the testing involved? And I want to just be clear, tonight was really like a sampler of this category of care, of this category of optometry. But what we can do is, there's going to be a poll showing up in just a moment here, where you can ask or request more information about Revolution, about neurovisual medicine, about both or neither. So if you're looking for more info, that's going to be the easiest way for us to get in touch with you. And then there's going to be a second pop-up to get your CE credit for our event tonight, that you'll want to complete in order to get that credit. So this is number 1. And I think within the next 30 seconds or so, you'll see a pop-up either in the center of your screen or the bottom left that will enable you to complete the post-CE completion form. Let's see if that'll pop up here.
So Matt, we captured all the CE information at the registration, so we can follow up with anyone who has that information missing and make sure that we capture it all.
Excellent. Okay. Well, with that, thank you everyone for being here tonight. Thank you for your engagement, for your questions. And we look forward to helping push this care forward and support more patients and more clinicians like yourselves to bring this care to your communities. So thanks again.
Thank you.
Thanks, everybody. Good night.
Good night.